Healthcare consumers, providers, creators, and advocates. Health and wellness should be everyone's top priority, and it's a dynamic topic, complex and sensitive to a vast array of factors from a local to an international scale. The healthcare industry is now at the forefront of everyday life and hopefully on the cusp of a renaissance. We're glad you've joined us for this series that explores the ideas shaping healthcare. I'm Minta Ferguson, Healthcare Architect and Director of the Strategic Facility Planning Group, McMillan Pasden Smith Advisors. And this is Ideas Shaping Healthcare. Today we're talking about telehealth and how two organizations are paving the way for telehealth across the state of South Carolina and improving patient outcomes. Joining us today is Dr. James T. McElligott, Master's of Science in Clinical Research, goes by Jimmy, and is the Executive Medical Director for Telehealth at the Medical University of South Carolina and an Associate Professor in the Division of General Pediatrics at MUSC's Children's Hospital. Additionally, he oversees the activities of the MUSC Center for Telehealth and is co-chair of the South Carolina Telehealth Alliance. Under his leadership, the MUSC Center for Telehealth has been designated a National Center for Excellence, and the South Carolina Telehealth Alliance received the American Telemedicine Association's 2019 President's Award. His personal awards include the South Carolina State Champion Award for Telehealth, MUSC's Physician of the Year Award, the 2020 MUSC Innovator Award, and the Margaret Jenkins Pediatric Teaching Award. Dr. McElligott maintains clinical duties in outpatient pediatric practice, newborn nursery, and school-based healthcare. He received his undergraduate education at UNC Chapel Hill, his medical doctor at the Wake Forest University School of Medicine, and completed his pediatric residency and academic generalist fellowship at MUSC. Thank you, Jimmy, for joining us today. I want to talk about telehealth today, which I know is near and dear to your heart. And I thought we could start with getting some background information about your involvement in a couple of different organizations. So the first is the Medical University of South Carolina's Center for Telemedicine. Can you give us a little history about the center?
Sure, happy to. I started my telehealth journey, if you will, as in my academic focus after I finished being the chief resident at MUSC, and got involved with health equity work. So seeing how bad off kids were in the state and if things we could do about it. And long story short is there was a lot of stirring interest in developing more virtual care and telehealth, but it was definitely pre-pandemic. It was definitely early days. And so I got involved from a health equity focused perspective and was lucky enough to be pulled into some grant funded efforts and then some state funded efforts to try to get more care out with these new modalities of virtual care or telehealth. Out of that grew an organized sort of grassroots effort that turned into an initiative for MUSC to create a physical center for telehealth and a hub that we could grow services out of. And because of my work in school-based telehealth and some other elements that I was involved in, I became the medical director for the Center for Telehealth. Since that time, it grew a lot over the sort of decade or so, even before the pandemic, and became one of the larger center for telehealths in the country with the assistance of both federal and state funds, as well as developing the ability to get services out. And from then the big thing that happened shortly after that was the pandemic, and then everything changed. And that's a whole nother book of history that needs to be written still after that. Along the way, we received some awards for our collaborative work across the state involving other health systems and entities in the state. And along the way, we were designated as a center of excellence in the country for some of our work and our outcomes work.
So I also understand that you're the co-chair of the South Carolina Telehealth Alliance. What is the difference in its scope and reach apart from MUSC's Center for Telemedicine?
Yeah, good question. The MUSC Center for Telehealth is really the service operational arm for the Medical University of South Carolina. So we develop services, we help other folks across the system develop their services. We work on the quality of telehealth being delivered, very operational things. The South Carolina Telehealth Alliance has a few areas of focus, but is really truly a collaborative entity. It is housed in the Medical University of South Carolina, but we do leverage some state appropriations to collaborate across the state. And what we do is we advocate for the use of telehealth, and we oversee a strategic plan that the state approves basically through the Medicaid office and says, we agree this is the work that needs to happen across the state. And the Telehealth Alliance provides that collaborative home to discuss what services we're going to get out where, and how we make sure that we don't overly compete in areas where there's a need, and make sure that we equitably distribute services.
With your capacity as a leader of the South Carolina Telehealth Alliance, one of your goals is to provide high reliability telehealth infrastructure and workflow that ultimately promotes effective care delivery. In your opinion, what's maybe the greatest challenge you experience with the built environment that serves as a barrier to that goal?
Well, it's an interesting question, and the built environment really isn't quite built for the use of virtual care, certainly. A lot of it sort of depends on the model of virtual care that you are doing. If you are fully virtual, you can be in an office environment or from a provider perspective and connect to a patient on their own device, and that's sort of an ideal situation. But many providers have a hybrid model. So they may be seeing patients in person, and they maybe see patients virtually, and they can't just run home, and they might not all have their space to go. And also many patients along their continuum will be using virtual care. Some of them may have digital literacy challenges or not have a device or not have internet, or there may be reasons that you want to do virtual care, but in a clinical space. So you can do more. You can do physical exam elements. You can collect labs and vital signs and do things along that way. So depending on the model you're trying to choose, really configuring the rooms for both the provider and the patient so that they can have a comfortable virtual experience, a private virtual experience, a secure experience. And internet bandwidth shouldn't be taken for granted. Even within fancy new buildings, you don't always have good internet everywhere, and making sure you optimize that experience again so that the users aren't interrupted by those technical elements.
You talked about digital literacy. So when you're working with different patients in different populations, different areas, how are you determining their level of digital literacy? How are you able to figure out where they are and meet them where they are, help bring them to where you would ideally prefer them to be?
Yeah, it's a good question. I think that the easiest answer is to say that we have a lot of work to do to get to that level where we are supporting patients, screening them, detecting them, and supporting them. Currently, a lot of the thinking is one, there's certain patients that will gravitate towards using virtual care. And those tend to be the right fit. They know how to use devices. They know how to get in. But what we are seeing is a very clear equity worsening, divide worsening. Everyone since the pandemic, all populations, all demographics, rural and urban, old and young, are all using telehealth way more than they used to. However, the urban, more affluent folks tend to, and there's some age elements as well, tend to use it much more. And so in some ways, we're worsening care equity divide. So the work that needs to happen is probably a referral mechanism where instead of those patients saying, oh, they're not a good fit I shouldn't think about scheduling for a virtual visit, do you do the opposite? Well, that patient may have access issues and they're the ones that need it the most, but we know there's going to be challenges. So likely what it'll be sort of at a clinical scheduling level or a sort of case management level, but we need new levels of resources. We need to be able to educate patients, provide devices, provide subsidized internet, and for those patients that could benefit the most. So right now, I suppose we are in a stage where it's the low-hanging fruit of, oh, let's use the people that are savvy. But really, if you're interested in health equity and mitigating care gaps, you really need to develop the resources to support patients to connect.
Thinking about access, I know that the repeal of CON in South Carolina is well underway. And there's growing concern about the access to care in rural and underserved communities. So how do you see telemedicine helping fill the gap moving forward in those communities?
I think honestly, in the years to come, it'll be essential. And it already is becoming that way, depending on the service line you're talking about. I think there will be attention given to providing services where there's an obvious market for it, and it'll always be hard to get services to the smaller communities. Virtual care really needs to be incentivized to be used in those areas. And we're seeing it happening a lot, already. We can look at the sort of number of specialty visits that happen in a certain geographical area across South Carolina. And we are already hiring up providers, nurse practitioners, PAs, physicians that really aren't asked to move to our state, but we need that specialty in these other areas. And to not compete locally, say Charleston or Greenville or Columbia, we don't have a ton of specialists, but we have some in those areas. You really need to develop those services to target the outlying areas and partner with local communities. So the elements that need to continue to mature are, how does the local and virtual teams work together? Working with a local clinic that might manage diabetes via the primary care resources they have, but you have a distant, say, endocrinology team. Like, how do they work together to maximize both resources? And some of the regulatory elements really sort of kind of discourage the use of virtual care currently. There might be geographical elements that are required to be in a value-based care program. You have to have X number of specialties within 20, 40, 60 miles. Well, that doesn't make sense in a virtual world. So how do we establish that the health system gets credit for access to those specialties or those other resources? I think increasingly in the areas outside that might have less focus that might drive some less focus because of the repeal of CON, the best thing to do is really have really strong, robust partnerships with the primary care entities there. Whether it be part of the health systems network or a federally qualified health center in the area, or even the free clinics in the area, to really work on integrated services that might bring a resource to the community, but it works through the primary care. Sort of a behavioral health collaborative care is a champion example of that, where you might have behavioral health case managers that are trying to figure out what level of care a patient may need. But a lot of those patients can be managed by primary care, but they need help. They need therapists, they need screening and guidance. And so those kind of elements where you have less resources, you're going to have to use innovative models. And to do so, you're going to need some sort of distance partnership, and hence virtual care steps in.
Thinking about like the partnerships, I know we do work also with public health departments and, what is the future of public health, and thinking about how it's not just about bringing the patients to the public health department. Many have, transportation challenges. There's a lot of services around children. What are your thoughts on how telehealth can help get into the communities and into the places where those members of the community who need the services are, whether it be, I don't know, like a school or a church? There's obviously language and cultural barriers sometimes that present some challenges to getting care. How do you think telemedicine will adapt to get into different places in the community?
Yeah, well, it is an exciting time if you work in this space like I do, in the sense that, from a value-based care perspective, which is sort of an approximation of trying to do true population health, if you will, a lot of those rules and elements are still based on what you can get done in an in-person environment. So most of the sort of credit you might get for doing good care is about getting sort of X number of things done, blood pressures taken or whatever. But the idea is that the patients have to come to you in a clinic somewhere in a community or far away in order to get that credit. When you start flipping it and you start going out to the patient in their community setting or in their home, you start thinking about your denominator differently. Maybe your responsibility is everyone in the community. Maybe every kid in the community deserves a bike helmet counseling or an autism screen from a pediatric perspective, versus how many of kids that came in to see me for a well child check got an autistic autism screen. So it starts to flip your mind of being like, is our population health approach even enough or adequate anymore. And so that's an exciting time. It's also a big challenge. What I would say is if you're incentivized to do that, if the more lives that you touch or you reach out to or you screen or you offer preventative care for is a incentivized structure, you're immediately going to decentralize your care team. You're going to use your respiratory therapist for the asthma folks. You're going to use your school environments where the kids are, for lack of a better term, contained, and you're going to go to the areas where the people are and try to get it done. So what I look forward to is a flipping of in a more ambitious population health incentive program that really embraces what you can do if you sort of take away the sanctity of the physician's office as where everything must happen. The idea really is about serving as many people as you can with preventive and screening therapies and approaches. And I think telehealth and virtual care will live and breathe in the future state of that environment.
I feel like there's a lot of to be determined relative to that in terms of how telehealth will play into that and help figure out where it really needs to be in that whole situation. So I'm kind of excited to see how that changes. I want to shift gears a little bit. We know that there is a large need for medical clinical professionals right now. And a lot of higher education institutions are creating or growing their programs for different types of clinicians. And part of that, they're focusing also on what is the future of telehealth, and then what does that look like in terms of an education setting. So what is your experience with the need for telemedicine training for medical professionals?
Well, I think it's an essential component for the future workforce and really current workforce. It does depend on what entity you end up working for, of course, where there might be more forward thinking than others, but just for a sense of scope of its presence in an academic center, you may run sort of 10 to 20% of all outpatient volume might happen virtually now. And that sounds like, oh, that's a minority, but before the pandemic, it was like point something percent. Like it's so much more of your everyday life doing this. And if you work in mental health, behavioral health, you may do majority of your work. Around MUSC, it's typically runs 75 to 80% of volume is actually happening over video. Patients prefer that. Providers can have a direct private conversation, and people don't have to come into a place and face stigma of coming to maybe a psychiatry institute all the time and those kind of things. So it's working and from that perspective, but also, like we just talked about, moving forward toward with population health elements, increasingly there's more and more outreach. So I would say the most important thing really is actually that multidisciplinary care team having embedded competencies coming out of school and coming out of early training. So for example, if you are training to be a nurse, you really should be aware that there's job opportunities doing remote patient monitoring, potentially working from home, following a digital dashboard of patients who may be flagged for high risk with their blood sugar or the hypertension, and you call them and you use your human touch and your human skills to reach out and talk to them and try to figure out what's going on. And then you might function under some standing orders and actually submit to the pharmacy to increase their medications. And you're doing a lot more care in between the doctor visits. And so getting the competency and the skills of that multidisciplinary team to work at the top of their license within the digital environment, if you will be really important. There's also just on sort of medical assistant level, there's a lot more telepresenting, being able to stand in a clinic and be at the other end of a video camera, representing a patient, talking to maybe a doctor far away. There's a skill there. And a big part of that skill is being an advocate for the patient. So sure, you could hold a electronic stethoscope in the right spots and hear the heart and lungs, but can you really make a patient feel reassured about the experience and things they may be afraid to ask? You can bring them forward. And truly doing this well will require the sort of human touch of this multidisciplinary team interacting with the technology and the patient. So I think the more you can go down a rabbit hole of this, but really every profession now with large percentages of care being delivered virtually, being competent in your role in that process is going to be really important.
Let's say we're designing maybe a health science facility for a higher education client. And they want to integrate telemedicine training into their program. Maybe they have simulation spaces in their program, and they want to try and look at, how they would train for a tele-ICU, telestroke, but they also have, a clinical setting. And so they want to be able to do outpatient, or maybe there's behavioral health, thinking about how to create flexible facilities that we can train medical professionals in those different types of telemedicine environments. How do you see that physically represented, or what would your be recommendations for how that should be physically represented in a facility for training?
Yeah, it's a great question. First of all, I think, having separate rooms where, you can really truly face the challenges of being at a distance from each other as a care team, right? And then you also kind of need a third party, which maybe could be done via software, watching eye contact and, professionalism and how people present themselves and how to navigate and give instructions on the other end. If you're doing a tele-ICU or a stroke consult emergency room scenario, great to have the true sim lab environment where the care team can be there. Increasingly, there's sort of the eye in the sky voice from the clouds kind of coming down being like, hey, can you get a blood pressure? Hey, can you do this? I'm going to place an order for, some medication while we're doing these things. You got to kind of embed in that room and you get used to that, there's different elements to it. There's also, the sort of integrated software elements, making sure that if they want to see what, say, a particular medication drip that might be going at what rate, you can zoom in on the elements, or is it embedded in a dashboard that the distant provider sees? And does the nurse have to enter these things? So it's just getting through the flow and just getting comfortable with the fact that not everybody's in the same room and working on that. So I'd love to see that challenged and the ability to throw curveballs, like, and then this happens, and then what are you supposed to do, just like you do in those environments. But you have to add on the layer of website manner and team collaboration that, I think all of us in the workforce in this post-pandemic world are getting used to Zoom calls and Teams calls and video calls, but I'm not sure when in the healthcare environment, there's an extra level of professionalism that's expected. So I'm not sure we know what that is yet, but I could see the education centers developing that and coming out, and they'll laugh at me. We actually did it here. We created a whole mock encounter for just a normal patient video visit and all the things that would be an ideal process. Making sure they know who you are, even like that you're not some stranger, and you could say your license number, or having good eye contact, make sure they're comfortable with the technology. If they have any questions. I failed it pretty miserably first time through, I
Oh,
thought I knew how to do
no.
a video visit, but it really wasn't true. And let alone, try to examine a stroke patient in a bed with a nurse at the bedside, and would I give the instructions correctly, and, those kind of things.
I'm envisioning like almost like how IT professionals will sit at a desk and they've got like 5 screens in front of them, and I can see like a joystick control, like zooming in into like an ICU room, looking
Yeah.
at different panels, and then connecting to the nurse station that's there, and just see this really high tech virtual world coming
Yes.
for all of
Well, that's what
this.
we do with the
So
tele-ICU here.
yeah.
It's here in some ways in a lot of settings, and just, being comfortable with that environment, coming out of training, saying you have some sort of extra badge of, I don't know if it's a certificate, but saying you know how to function in a sort of connected environment. The other, if you work in a hospital now, say as a nurse in an emergency room in South Carolina, every single hospital, I believe, in our state, just about, there's maybe a couple I can think of that are maybes, are using beaming in virtual teams.
Mhm.
So it's not like it's just this MUSC hospital or that one. It's everywhere. And so people are learning on the job right now, but they really should come out of training sort of, this is normal. And they'll wonder why there's even a medical director of telehealth one day. We're like, it's just care. It's not called anything, but we're not there yet. And, our workforce is getting exposed to this a bit, but it's a lot more is happening on the job training than in the actual training environments where it should.
You've mentioned workflow for telehealth.
Hmm.
With your experience in the South Carolina Telehealth Alliance, do you have like 3 or 4 must-haves for an effective telehealth workflow?
When you're at a distance, process matters even more. So having a detailed process mapping and thinking it through and then modifying as you go, but sort of hardwiring it is the most important thing. because there's just inherent weaknesses from not having the front desk near you or not having at the elbow support or someone, the down the hall effect. You can just grab somebody and get some help. You really have to have process in place to think of it. So in general, that's sort of a truism, if you will. The other part is that virtual care and in-person care typically should have different goals. So, in-person care tends to lean towards it's hard to get to me, so I should be comprehensive. Well, for virtual care, you might think of it a little more like discrete continuum of care. You might say this visit is about making sure your diet is correct, but you do that. You don't necessarily do everything. Or if you're more seriously getting a stroke, you really have someone had a stroke, your job is maybe not doing all the medical care for that patient, but as the neurologist beaming in, you should decide if they need a really high level of therapy or not. Do they need clot busting therapy? Should they go to get a procedure, and when? Should the helicopter fly? You have discrete decisions to make quickly, while the rest of the care happens locally in person. So that type of workflow and understanding the goals of who's doing what is important. I laughed a little bit because, when you ask the way you asked the question about what's really important, we have some what I sort of call cardinal sins of telehealth that people, including ourselves, commit all the time. And they're kind of obvious, but the excitement around doing this and the work around doing these things can lead you to sort of skipping these sort of really big things. So one would be you put out equipment because you have a grant or you have a lot of initiative, but you really don't have providers lined up with a literal schedule ready to see them. You think that if you build it, they will come, but it's actually really hard to change a provider's life. You have small practice, big practice, getting them to be available at that right time is there. So that's one of the biggest things. People buy equipment and they said, oh, we'll figure out the service later. Well, the equipment was the easy part. The second part is not having a clear path to the patient to get in front of the camera or device or whatever you're trying to do. That also seems obvious, but it's really easy to do all this work, get everything lined up. But the patients are used to doing their usual cultural healthcare access way. Like if you go to an area where people don't go to the doctor very often, this doesn't automatically change that. And also the nurses, if the doctor's like, I'm just going to remember to pick a few patients that'll be good for this. Well, have you ever seen a doctor remember anything in the middle of their day as they're trying to do stuff? No, you might want to hardwire it for the schedulers or the discharge process. You have to really think through, well, how are these patients going to be guided to engage with this system? I think one way to think about it is if you're setting up a virtual care service, it's just like building a clinic. You have to think of all the things when you're putting the bricks down and the finances and the charting and all the stuff in that built environment that you have to do. But in a virtual clinic, it might get stood up much quicker. Like it might just happen. You start doing it. But if you haven't, covered your bases on all those sort of dry elements that you have to like think through, then you're going to have weakness and you're probably not going to go to scale.
When I think of telemedicine, I often think of like a virtual visit where I'm seeing my provider on a camera and talking. But oftentimes when I think about it, I don't know why I have to see them when really we're just communicating back and forth. So I'm kind of wondering, like, is the video piece critical? Is there ever a need not to have it? Or is it I mean, you talked about the eye contact and kind of that bedside manner, if you will, for telemedicine. How critical is the video component to it?
Telehealth, if you will, is usually defined as care over distance with technology. So two cans and a string, if you call that technology, is it. So you shouldn't be pigeonholed to one modality or another. And I like to say it should be goal focused. So asynchronous, just messaging approaches or things that don't even happen in real time certainly have a place. And if convenience and low risk approach is there, then that should be fine. It's also fine. An audio call can go a long way. You can build a relationship, with a phone call. So understanding the value add of different modalities is important. So it kind of depends on what we're talking about. But I would say the visual element, we are visual creatures for the most part. We do eye contact matters, body posture matters, environment matters. In those sort of establishing relationship things. I mean, if you're coming in and, you've just got pink eye and it's run-of-the-mill stuff, like how much, I mean, that's a bad example because a picture of the eye would be good. But, you get the idea, some things matter more than others. I do think being sort of open to the idea that, again, what we're all trained in and what we're used to is going to the doctor, spending an X amount of time, and we're all trained to sort of build a relationship really quick to solve the problem that the individual has in a healthcare and create a care plan and send them back out the door. So a lot of that is big rapport building right away. So I do think there's an element in the video that sort of says, oh, we have to build this rapport so they trust me. So when I give them a recommendation, they'll do it. But I'm not sure that's true for everything, for a follow-up visit, for all these others. So anyway, long story answer is yes, you're absolutely right. Video is not essential in all settings. And if we're trying to be more efficient in our care delivery, we should be honest about that. But there's definitely a big role to have that human element between two people who are deciding on a plan on someone's care.
Kind of thinking about where we're going in the future. I know no one has a crystal ball. It's hard to tell, what exactly is going to come, but are there evolving technologies that'll advance telemedicine capabilities or even services? Are you thinking about that as part of the organizations that you're leading or involved in about where that's headed?
Yes, absolutely, especially in these times where things are changing really rapidly. You know, here at our Center for Telehealth, our mission statement is includes efficient, effective care in it. So really we tried to set at the get-go that it wasn't about video or audio or even messaging or texting. It was about being efficient, delivering care more efficiently. That's what we're supposed to be doing. So I think if you believe that and you expand your thoughts about it, definitely artificial intelligence comes to mind right away. The idea that getting a patient what they need sooner and doing it accurately, those kind of approaches are going to have a big part of that. There's still going to be a huge uh, human element for the near future because of reliability of the technology, because of the importance of healthcare, and because of hallucinations that artificial intelligence tends to do when they're documenting and things like that. So we're not there yet, but in discrete areas, the system's going to be a lot better. We're going to find patients that really need blood sugar control more granularly there. And then the wonderful nurses and physicians and everyone where they interact will be more targeted and more efficient. So I think that's kind of the biggest one, but it's a big open area of really how do we engage humans to get ourselves to do the right things for our healthcare at the right time, and those engagement technologies are going to play a huge part and already are. There, people always ask me, what about when AI comes to healthcare? And I said, well, it just happened.
I think that's on everyone's mind right now.
Yeah,
And
it's undeniable, really, that it'll add efficiency to our care systems. It's just a matter of how and when and why. I will say there's something about the virtual care elements that because the communication is already happening over distance through technology, you would think the AI elements can leverage that data quicker. So you and I talking on this call, we could have assistance with a bot because it's not an ambient thing. It's through microphones. So, telehealth is likely to adopt those elements quicker.
I guess if you had one major goal that you would like to see happen with telemedicine in the next, say, like 5 to 10 years, what would that be? What's that big kind of outrageous goal that you would have?
Honestly, it's what we started with. I mean, really, what's really been exciting is we've had the opportunity and the allowances to be goal focused and regional focused on things that aren't always market driven, right? That we really to do healthcare of what we all set out to do. And that's the real passion part of it. If we can get more wins, increasingly more wins, where we can show that we can do these things differently. And though the model's changing, we're going after the most important things that need to happen, interacting with humans to make this life a better place, then that's a laudable way to answer your question, but I can actually see it happening. If we just keep going, I think we can look at the heat maps of kids that aren't screened for autism, and we can do things like, well, maybe let's not take them to a weird place and have them interact in a cold room with people they don't know. Why don't we monitor them in their home in partnership with their parents and understand their approaches and understand their precise, social challenges that they have and provide therapies that target that. But we make sure that every household has an opportunity for that, not just ones with certain resources and those kind of things. So if you can just focus on what the world needs,
Mhm.
it does feel like sort of using distance technologies to solve your problems of staffing and distance and equity. It feels in reach. And so I'd hate to see 10 years to pass and us not have some more big wins on those front. So, and to sum it up, I think the thing that drives me the most is I think telehealth's for everyone, but I really want to see it solve equity problems.
Think about like if we took where we are now, or maybe even where, for example, like the Center for Telemedicine started and, time capsuled it and went forward 10 years from now. And you think about the progress made and it'd probably be quite a bit. People may not recognize, the original.
That telestroke story is what really has encouraged us on, where before we did telestroke, now every patient in the whole state, every citizen in the whole state is within 1 hour drive of expert stroke care. Before we did the program, maybe like 30% of the population was within an hour drive. And when we tried to figure out some of the data, we realized a lot of the community hospitals didn't even order the clot busting therapy because nobody ever ordered it in the hospital ever. And so to go from that to, everyone's within drive of an expert stroke center, like it can be done. And we have reduced our mortality across the state, which is, it's a simple statement to say, but that's just less of our loved ones have died because of that program.
Well, thank you, Jimmy, for joining us. I really appreciated your time and giving us your thoughts on telemedicine today.
Oh, you made it easy. Thank you very much.
Now it's time for the pulse check. We want to cover 3 major takeaways from today's episode. I think the first one is clearly the expansion and further integration of telehealth provides opportunities for equity and access in healthcare for different populations, and even perhaps more so for underserved communities. The second, I think there's an opportunity for schools and teaching hospitals to develop standards and curriculum for telehealth in their programs, and creating very real and lifelike scenarios for them to work through. And then finally, telehealth, it seems, is going to begin to naturally dovetail with AI and other technology advancements. And I think we can expect to see the operational flows and the facility environment morph as a result of this.